Thank you so much, sir. And I thank the scientific committee for the invitation. I'm slightly sorry I have a bad throat to talk, but hopefully my presentation would be much more clearer than my voice right now. So the topic that was given to me was red flags in management of joint pain. But before so this works, yeah. Before I start, just a brief introduction of what I as an immunologist do. So we deal with disorders of immunity. What are disorders of immunity? So these can be broadly classified into four categories. The first is when your immune system is not functioning. The purpose of the immune system is to fight infections. Any foreign object that is coming inside the body is to be dealt with. So if the infections are not dealt with well, these will cause what is called as immunodeficiency diseases or immune dysregulation disorders. Here you will have infections that are frequent, severe infections by unusual organisms that are often difficult to treat, and in a lot of children you would have failure to thrive. The second that is very commonly associated with us immunologists is immune mediated inflammatory diseases. These are what in classical terms are called as rheumatic diseases or rheumatological disorders, and now we call them more appropriately as either autoimmune diseases or autoinflammatory disorders. The third set of disorders that I also see is called as allergic disorders, and allergy are again a kind of immune dysfunction where the immune system goes into a hyperdrive to an allergen or an antigen it should not have reacted to. So these are basically the immune system reacting with a hyperreactivity state. The fourth I don't deal as much, but it is your body's immune system's function to fight cancer cells. So if the immune system is well, you should not have cancers. That is why as you age, your immune system weakens and the chances of you having cancers increase. In the newer set of therapies that have brought about in cancers, you have a lot of immunotherapies coming up that improves the immune system and increases the clearance of cancer cells. So what are red flags? Joint pain is an extremely common symptom. If I ask anyone who's present here, have they ever had joint pain in their lifetime? Most of us would say yes. So most joint pains are benign and resolved with self-care, but sometimes this can be a serious signal to a serious cause, and red flags are actually warning signs that require prompt medical attention. Early diagnosis and treatment would lead to better outcomes. So I've divided red flags into two specific categories. One would be systemic red flags, that is if the patient has symptoms outside the joint and these are the symptoms present, you need to be more careful about what the patient has. So fever with chills. If the patient has had fever, this is an indication that this might be either an infective or an inflammatory etiology. If the patient has had unexplained weight loss, night sweats, if the patient is having extreme amount of fatigue or severe tiredness, a rash, a focal neurological deficit, either a CNS deficit, that is patient has difficulty remembering stuff or has had a stroke, or a peripheral neurological deficit, something like a neuropathy, a foot drop, or decreased sensation somewhere, and any systemic symptoms. So if you have something like a red eye with joint pain, oral ulcers with joint pain, any involvement or lab abnormalities in the heart, lung, kidney or liver, all of these would be red flags for joint pain. Then there can be joint specific red flags. So once you are examining the joint, if you are having extreme swelling that is warm and red, that again comes as a red flag for the joint pain. If you have pain that is out of proportion to the amount of limitation the patient has, if there is an abrupt onset of pain, especially when there is no history of an identifiable injury, if you have features of joint instability or joint locking, if you have significantly reduced range of motion, and if the morning stiffness is more than 1 hour, and if the patient has inability to bear weight, all of these are joint specific red flags. So just in deciding what is a red flag and what is not, we need to understand how to approach a patient who has joint pain. So a lot of times patient confuse between where is the pain arising from, whether the pain is actually from the joint area or from the peri-joint area, from a side that is actually away from the joint, or that is in the soft tissue or bone adjoining the joint. So if it is in the joint area, that is any pain or swelling or inflammation that is arising from the joint is called as arthritis. If it is from the structures around the joint, so is my, yeah, that is visible. So if it is from a tendon or a ligament or a sheath that is around the joint, this is called as periarticular pain or periarthritis. These could be tenosynovitis, tendinitis, enthesitis, bursitis, etc. It can be from slightly away from the joint. So bone pains, muscle pains and fibromyalgia can also be joint symptoms that are there in these set of patients, and the pain can be referred from an external site. Now, then you also need, once you have defined that the patient has had joint pain, the next important question is whether this is inflammatory or non-inflammatory. So the most important question that you often ask is whether the stiffness is there. Early morning stiffness that is lasting for more than 1 hour is usually indicative of an inflammatory articular pain. Usually, even patients who have had some degree of osteoarthritis, they would have some degree of early morning stiffness, but that is usually within the range of 30 minutes. You use the joint so with activity. So most of these patients would complain that their hands are very stiff in the morning, and as they go on working, their joint pains improve. If there are symptoms that are worsening as the night progresses with periods of inactivity, this again would indicate inflammatory pain. If there are presence of systemic symptoms such as fever and weight loss, and if there are elevated inflammatory markers, all of these points towards uh, inflammatory joint pain. Now then, there are a set of questions that you need to ask. What was the kind of onset of that joint pain? How did it progress? What was the duration? Whether that this was acute in onset or chronic? What were the number of joints involved? Whether this was symmetric in onset or asymmetric in onset? Were these axial joints or peripheral joints, and what were the extra-articular features? So I have a few cases through which we'll understand how to identify the red flags. So we have a 40-year-old male who has had recently a post-renal transplant, is on immunosuppression, and came to you with acute onset of right knee monoarthritis. He has fever, the knees are red, hot and tender, and there is significant restriction with very high pain. So any monoarthritis to remember, if there is one single joint involved, it is red, hot and tender, the first suspicion one should have is of psoriatic arthritis. Monoarthritis is a rheumatic emergency. The rheumatologists don't have a lot of emergencies, and the ones we have are very dear to us. So this patient actually underwent excision, and this was drained outside before they came to us, but see the amount of pus that was draining out from the joint itself. So septic arthritis is classically divided into two parts. The non-gonovocal septic arthritis, that is usually caused by Staph aureus, and the non-gonovocal septic arthritis, which is the classical arthritis that we present with a more oligoarticular or a polyarticular presentation. We would have significant tenosynovitis in these set of patients, and more than one joint are usually involved. With the advent and the advertisement regarding safe fix practices and sexually transmitted diseases, we see much less gonovocal septic arthritis as compared to what we were seeing earlier. The second case is a case all of you see very commonly. So this is a 40-year-old male who is alcoholic, presented to you with acute nocturnal onset of monoarthritis. This was exclusively tender with inflammation. There was edema and deep formation of the joint involved, and the patient did not even allow you to touch the joint. So you can see that the first MTD joint is exclusively red, hot and swollen. We aspirated this joint, and what we saw was crystals of uric acid. So this is what is doubt. Now, crystal arthritis can again present with an acute monoarticular severe presentation. The important point to remember here is serum uric acid is not a diagnostic test for gout. Up to, so if you say that everyone who's above 40 is obese, as those cardiovascular risk factors, including diabetes, almost 30 to 40% of people have higher levels of uric acid. A red hot peripheral joint that is more common in the lower limb as compared to the upper limb, especially the first MTD joint, with an onset over the hours, is classically gout. Gout is very rare in females. So if you find an elevated uric acid that is there The most common cause of first NCT arthritis or pain is osteoarthritis. The gout might not be one of the common diagnoses you might get there. And if a patient is presenting to you with a chronic polyarticular presentation or a low back pain presentation, need to be very suspicious to suspect gout in this type of patient. Something that can commonly present with a gout-like presentation is called as CPPD arthritis, calcium pyrophosphate depositing disease, and these would again present usually with a red hot knee. Most of them have pre-existing osteoarthritis. So what they present is they have an history of that would be suggestive of osteoarthritis, and they would present with an acutely red hot tender knee with that is going all stable. This is most likely because of calcium pyrophosphate disease, and effective management usually makes them all well. The third case is a 42-year-old male who has come to you with left knee pain and swelling for the past 6 months. So mind you, this is a chronic arthritis and not an acute presentation. He has some early morning stiffness. There is no features of active tuberculosis, past tuberculosis or TB contact. The left knee is cold in swelling, so there is no worm, there is no erythema. It is swollen but not tender, and there is decreased range of movement. You did your battery of tests. Upon the X-rays, you have the classical features of an infective, chronic infective arthritis, and this turned out to have tuberculosis. So, if you have someone who has chronic monoarticular inflammatory arthritis, which usually involves knee joints more commonly than the other joints, suspect tuberculosis. This is still the most common cause of monoarticular inflammation that is chronic. Other infections can present. In children, if you are seeing these symptoms, this could be a manifestation of oligoarticular or polyarticular juvenile idiopathic arthritis, and then there will be other causes that are less commonly seen. The next case is, I'll just go faster. So next case is a patient who has had left buttock pain. So this is what they come with: low back pain, recurrent buttock pain. You would have suspected them to have spondyloarthropathy, but the pain is intensifying with both activity and rest. There is some response to NSAID, but they've had significant weight loss over the last 9 months associated with decreased appetite. The features are again on examination consistent with a severe joint involvement, and you did an MRI. Yeah, and an MRI that was done was suggestive of some periarticular inflammation. Usually, the classical spondyloarthritis MRI would only show joint involvement. If you are seeing features that are outside the joint, this would suggest that this would be an infective pathology. So here, if you can actually see this area, it is showing that outside the joint you have collection of the inflammatory material along with the bone marrow edema that the patient has, and this again would be suggestive of an infective pathology. So back pain has its own specific red flag. It is if a patient with back pain is coming to you at extremes of ages, if there is history of trauma, fever, significant weight loss, pain that is disturbing sleep, there are focal neurological deficits such as the patient does not understand when the urine is coming and there is incontinence of pure urine. If there is history of a previous fracture, if the patient has had prolonged usage of corticosteroids, and if there is a history of malignancy, all of these are red flags for back pain. And my last case is a 20-year-old female who was presented to us with a plethora of symptoms. She has fever for the past 6 months, polyarthritis for the past 4 months, recurrent oral ulcers and photosensitivity. She has pallor, icterus, there are swollen and tender joints, and there is abnormality with the liver and spleen also. You find multiple blood tests that are abnormal, and this finally turned out to have SLE. So if you have a chronic polyarticular inflammatory arthritis, rheumatoid arthritis is the most classic type. But if you are having systemic symptoms, think about the autoimmune rheumatic diseases or connective tissue disease, lupus, dermatomyositis, systemic sclerosis, LCD, Sjogren's, all of these can present with variable systemic symptoms. Something that is very important is leprosy, and just a few cases of how innocent red flags can be. So I had this, yeah, for just 2 minutes more. Yeah, 2 minutes more. So I had this very interesting guy who had come to us. Now, all of us in anxiety have that habit of chewing our nails off. And when I was examining this patient and I asked him, you have chewed more than half of your nails. Did you realize did you have pain when you did that? So the patient said, "नहीं sir, पता नहीं, ये खबर ना पड़ी कि क्या रे कवाई गए." Uh, I did a detailed neurological examination and I found that there were no sensations here. This finally turned out to be leprosy. You can see the ears are extremely infiltrated and the arthritis here because of hunky disease. This is another case. While I was examining this patient, we found that she had no hair in the anterior abdominal wall, and this again raised my ear, and I asked the patient કે આટલા આમ જ એરિયામાં કેમ શેવિંગ કર્યું છે તમે કેમ આખામાં નથી કર્યું તો પેલા કીધું કે સાહેબ અહીંયા આવતા જ નથી બહાર જતા રહ્યા છે. So then again this was a sign that there is some profit disease here. Our neurological examination was again done. There were hyperesthetic patches, and this again turned out to be hunting. So just to summarize, if you have musculoskeletal pain, and if that is, you have to differentiate between whether this is articular, periarticular, non-articular, or deferred, whether that is inflammatory or non-inflammatory. The most common cause for non-inflammatory pain is osteoarthritis. If this is inflammatory and monoarticular joint involvement is a red flag. So inflammatory arthritis that is involving just one joint in itself is a red flag. If you can take this message back home today, I'd be more than happy. Oligoarticular involvement or spinal involvement in cases of infection, tuberculosis should be ruled out. Spondyloarthropathy are the more common causes. And if there is polyarticular involvement, look for systemic features. You might be having autoimmune